Hello, everyone. Welcome back to the Medical Teaching Podcast for both teachers and learners. Today I'm going to be talking about how to teach learners about any medical topic, any medical disease topic, I should say. So, the the thing about it is that when I was a resident, I remember kind of not quite knowing exactly how to approach teaching various medical topics. What scope should I include? Should I include all the epidemiology? Should I include, this and that? I have found that I use a very simple structure across all disease processes now. And then obviously for specific disease processes, I will change it or emphasize different things, but by and large, I follow this structure. So number one, I go over definition. Then number two, I walk through the pathophysiology. And when I talk through the pathophysiology, I'm not talking, down to the cellular level and, CAMP does this and GMP does this and ADP does this. I don't really do that. The pathophys, I try and keep it very clinically relevant. I talk about the pathophys that's going to actually directly affect the clinical manifestations. So from the pathophys then comes the discussion about the clinical manifestations. So because of this pathophys, then we have these clinical manifestations. And then from there, I talk about diagnosis, how to make the diagnosis. What are the diagnostic criteria? Again, that should ideally stem from both the pathophysiology as well as the clinical manifestations. And then finally, management. Management should, again, flow from the pathophysiology as much as possible. So that's it. Very simple. Perhaps a little bit of basic epidemiology, no more than two or three most notable things, because if the goal is for our learners to retain and to remember these things, we've got to make sure we hit the most important things and keep it simple. That is the key thing. So let's delve into each of the pieces separately now. So definition, of course, this is a very critical piece. So definition is something that you have to kind of know the disease process in order to come up with a proper definition, right? Because a lot of times people, when thinking about the definition, they'll talk about a piece of the disease, they'll talk about a part of the disease, they'll talk about the pathophysiology of the disease, they might talk about some of the clinical manifestations, but at the end of the day, you want them to be able to define the disease as it actually stands. So I have tried to prompt my learners to think of every disease process as for the definition, to think of such and such is a disease process wherein ... So for instance, atrial fibrillation is a disease process wherein you have abnormal electrical activity in the atria, right? And then that abnormal electrical atrial activity is what then the pathophys is then what causes for the atria to fibrillate. And as a result of that fibrillation, then you have stagnation of some blood or eddying of the blood at the left atrial appendage, which can lead to clotting of that blood, and then greatly increases the embolic stroke risk when the heart then reverts back to sinus, or when the atria, when the atria, goes back to a sinus rhythm and contracts with the proper atrial kick, then that could dislodge the left atrial appendage clot and then move to the ventricle, and then move from the left atrium to the left ventricle to the aorta, and then up to the brain, right? So that's the pathophys for stroke, right? And then talking about the pathophysiology of tachycardia-induced cardiomyopathy, and I'll make it real simple. I'll just say, hey, the heart is a muscle, right? So, if you have your learners kind of say, okay, if you had to bench press, 100 pounds or 150 pounds or 200, whatever, and you had to bench it like at this speed, then you could do it. But if you had to do it like this, it would be a lot harder, right? And your muscles would give out, and our learners will understand that. So you who are learners who are listening to this would obviously understand that, and then say the same thing as with our heart, right? Our heart, if it's beating at greater than 150, 140, 150, 160, 170 for prolonged periods of time, it's going to give out tachycardia-induced cardiomyopathy. So then just kind of spelling out the pathophysiology. Then after that, the clinical manifestations. Well, as a result of tachycardia-induced cardiomyopathy, you will have you could potentially have the manifestations of all the heart failure manifestations, right? You could have shortness of breath, you could have dyspnea, you could have dyspnea on exertion, all of these things, right? So due to the tachycardia-induced cardiomyopathy, the clinical manifestations of the embolism from the left atrial appendage up to the brain, then of course could lead to all the stroke clinical manifestations, right? And then of course the atrial fibrillation itself can lead to the palpitations, can lead to fatigue, can lead to these some even chest pain sometimes, right? So these would be the kind of things we would want to talk about with our learners, right? And then but again, always relating the pathophys to the clinical manifestations. Then talking about the diagnostic criteria, how do we diagnose it properly, right? Getting an EKG, 12-lead EKG, right? That's one of the cornerstones of evaluating atrial fibrillation. Then putting them on cardiac telemetry. So these are the kind of things that we would talk about, right? And then being able to identify it on EKG, right? It's got to be irregularly irregular, right? It's not going if it's perfectly regular, but then you've got flutter waves, then it is atrial flutter, right? Not atrial fib, right? If it's perfectly regular and there's a P before every QRS complex and it's 140 beats per minute, then it's sinus tachycardia. It's not atrial fibrillation. So talking through the actual diagnosis of atrial fibrillation, right? And relating that to the pathophys again as well. Those fibrillatory waves that you see on EKG is in fact the abnormal electrical activity that you see. That's the pathophys. And then finally, the management, right? So the management focus for atrial fibrillation, we're talking about three main goals, aren't we? We're talking about the prevention of stroke, right? Prevention of that embolism. So what do? We're going to have to anticoagulate, right? But how do we decide who to anticoagulate? The CHADS-2-VASc score. Then I would go through the CHADS-2-VASc score, go through all the different pieces of that with my learners, right? C stands for congestive heart failure, H stands for hypertension, H for greater than 75, 2 points, so on and so forth. And then going over addressing the tachycardia-induced cardiomyopathy. That is why we do rate control, right? That is why it is so important for us to slow that heart rate down, right? If it's sustained for greater than 20 minutes or 30 minutes, greater than 140, then you're going to, if it hadn't resolved on its own within that 15-20 minute time frame, then it's time to slow it down. What are you going to do? You've got to go through that decision tree, right? So if they have tachycardia, if they have a heart rate greater than 150s, 140s with atrial fib, number one, are they stable or are they unstable, right? We've got to decide. So and then if they're unstable, we're going to have to cardiovert. If they're stable, then we've got to decide what is their blood pressure, right? And then we've also got to decide, do they have delta waves, right? So these are the kind of things so again, from the pathophys, we decide how we're going to teach the management, right? So prevention of stroke, prevention of the tachycardia-induced cardiomyopathy, and then finally the addressing of the signs and symptoms, right, of atrial fibrillation. So that can be helpful, I hope. So that's how I teach any medical topics. So then you can apply these same principles to talking about congestive heart failure, talking about acute coronary syndrome, right? So, and of course it varies for each topic. So acute coronary syndrome, if you're talking about that, you're going to have to give not just one definition, but three, right? So acute coronary syndrome is a disease process wherein you have insufficient blood supply, insufficient perfusion of the heart, right? But then you've got three different you've got three different diagnoses under the acute coronary syndrome. You've got unstable angina, you got stable angina, or excuse me, what am I saying? NSTEMI, and you've got STEMI, right? So then going through each one of them, right? What's unstable angina? That's where you have cardiac ischemia but no infarction. NSTEMI is where you have a partial thickness infarction. You have death of cardiac tissue, and then a STEMI where you have a full thickness transmural infarction, right? And then going through the clinical the pathophys of each, and then talking about the clinical manifestations of each. So this is how I teach all topics: GI bleeding, chronic liver disease, hepatorenal syndrome. It varies, like I said, and all the things that you have to go through are going to be different, right? We're not going to be talking about Chad's too fast scores with chronic liver disease. We're going to be talking about MELD scores. We're going to be talking about the different parts of the MELD score. Why do you from the pathophysiology, why do we look at the total bilirubin and the INR and the creatinine, right? These are the things that you're going to want to tie together for our learners so that way it will be clear and more memorable. So I hope that's helpful. This is my basic structure for how to teach any medical topic. I hope that it adds value to you, and would love your thoughts, and I will talk to you on the next episode. Thanks.